Good afternoon, everyone, and welcome to today's webinar called Improving Client Outcomes, Understanding Theories of Change, and Designing Effective Interventions with Dr. David King from Indiana Wesleyan University. This webinar is also co-hosted with them. So if you have any questions regarding the university or their programs, you're welcome to drop those in the chat. A few housekeeping items. This webinar will be recorded. If you need any CE or McBAP, if you need any McBAP or social work CE, please drop your name in the chat, and afterwards I'll get out a survey to you. And then once the survey is received, I will send you out a certificate. So I'd like to give a little bit of information today about our presenter. David King has been working in the social work field for 30 years, providing services in church, community, and private practice settings. Dr. King holds a doctorate in social work from Walden University in social work administration, a master's in social work from the University of Kentucky, and a master's in pastoral counseling from Asbury Theological Seminary. He is a licensed clinical social worker in Michigan. Over the course of his career, Dr. King has worked with children and families and individuals with developmental disabilities, chronic mental illness, and substance use and co-occurring disorders. Dr. King has been teaching social work at the graduate level since 2009 and is currently the program director for the MSW program online. His interests also include integration of social work and Christian faith, ethics, and outcomes-driven social work practice. Please welcome Dr. King.
Thank you, Kristen. I appreciate it. Nice to meet all of you. If you want to put your faces on at any time, that's fine, but not required. Kristen mentioned again that we want to have some time for some questions and answers if needed along the way. So I'll probably stop kind of after some of the major sections of the presentation and give you a chance to do that. So like Kristen mentioned, I'm actually from Michigan, even though I work for Indiana Wesleyan University. I teach in an online program, so I just travel down there sometimes. So most of a chunk of my career has been in the community mental health system here in Michigan in a variety of roles, from case manager, supervisor, program director, different levels. So happy to be a part of something from Michigan and helping to present some information for you guys. So thanks for having me today. I'm going to share my screen so we can get started in terms of the formal presentation here. All right. This is just my email address. Again, if you have questions afterwards or want to contact me for anything, that's my email address at the university. That'll also be on the copy of the presentation that Kristen sends you. These are just our learning outcomes for the day. I'm not going to spend time going over those with you, but that helps you kind of know where things are going. This is kind of a brief overview of where I want to go today again, and talking about designing effective interventions. There's kind of several layers to that process that we're going to be going through. So one layer is the clinical foundations layer, and we're going to be talking about assessing and engaging worldview, which will explain more of what that means, identifying and operating from a relevant theory of change. And again, we'll talk about what that means and how that connects. And then the next level is kind of clinical strategies, which includes maximizing clinical competencies for the therapist, choosing evidence-informed or evidence-based interventions, and then finally clinical evaluation, how we actually monitor and identify outcomes and continue to improve outcomes as we go. So with every clinical process or every treatment process that we're engaged with somebody, it's really kind of this bigger picture process that's happening behind the scenes, and that's kind of an ongoing component of the work. And sometimes we lose that, which is why I want to kind of give this presentation about the overall process that is important. So here's kind of my focus today. First of all, we're going to again spend a chunk of time talking about the importance of worldview when it comes to treatment planning and design versus kind of the historical idea of cultural competency, and kind of talk about why that's different and why it's important to be thinking a little bit more broadly about that. Again, today is going to be a bigger picture view where we're focused on process and kind of walking through a process as a whole. And so there'll be lots of kind of self-reflection and questions that I'll be asking you to consider along the way, and not just providing all the answers. So I mentioned to Kristen, again, I tend to over-prepare, so we might not get through everything today, but you will have the chunk of stuff you need and the vision, hopefully, that you need. And I say that because oftentimes my goal and my role as an educator, and also when I was leading programs, is I tell students and I tell people I work with, like, my goal is to help you become a master clinician. When we work with people, we work with difficult situations, our goal is to have a full skill set, a full range of tools to draw from, and be really good critical thinkers in terms of how we work with people to help work with their individual situations in order for change to occur. We don't want to just kind of do cookie cutter or one size fits all types of things. That tends not to work very well. So that's a little bit why I tend to go bigger picture on this stuff. So when we think about change and thinking today about theories of change and designing effective interventions, we have to recognize the complexity of change. And so some of the questions that I'm hoping to address are issues that we struggle with around why are best practice or treatment models sometimes difficult to implement effectively. Sometimes organizations really struggle with that. They might spend a lot of money on a particular training or something, and then it still doesn't kind of get the results that they want. And so the question is, why can that be difficult? What are some of the issues involved with that? How can clinicians practice more effectively with clients from increasingly pluralistic backgrounds or perspectives, whether that's political issues, sexuality, social issues, religious beliefs? Depending on where you live, there's just a lot more folks from lots of different backgrounds, or as our culture has become increasingly fractured or politicized, just more of these issues kind of come into play for folks as they work with them in various settings. How can clinicians think more holistically about the process of healing and change in mental health and design more individualized interventions? Again, sometimes depending on where you work, our system gets very caught up in kind of having to do things its own way or follow certain rules, and it can be a struggle in terms of thinking more broadly about people and how to help. And really the bottom line question again is, how does good therapy actually work is the question that we're always trying to answer. Here's a quote from some authors recently about the complexity and challenges of change and some of the things I just mentioned. So they say, showing that a therapy is effective in treating a mental health disorder does not provide evidence about how a therapy works. So just because we can say, hey, this treatment seems to get good results, it doesn't necessarily always tell us how it's actually working. Showing how a therapy works is much more complicated, requires a whole series of studies and experiments, and will never have the strength of evidence of randomized control trials showing that a therapy works. And partly that's just because humans are complicated. There's a variety of factors that we're going to be looking at in what brings about struggles in people's lives. And so we always want to be careful not to overly reduce or simplify how change actually works. So we want to start with this first clinical foundation of assessing and engaging worldview. This may or may not be a new word for some of you or idea for some of you. And this is going to be the more philosophical part of the conversation, but a very important kind of thing to think about as the foundation to the work that we do. So first of all theories and interventions come with a worldview. So whether you're going to get help for yourself from a particular provider, or whether you're providing services of some kind or a particular treatment framework, we have to recognize that all theories and interventions come with a worldview. And in fact, all people come with a worldview, which is a mental framework or behind the scenes operating system from which we form and interpret ideas and prioritize our values. So it's behind the scenes. So we're not often thinking about it. Most people don't think about it. It's just kind of operating behind the system, and they are reacting to life and processing life and thinking about life from that kind of filter and perspective. So we're going to talk a little bit more about what that means. Worldviews are based on specific underlying beliefs and assumptions about core human questions, like what are the origins and nature of life, relationships, or reality, or what it means to be human or to be a self. And really, it's ultimately about what truth is, what it means, and how it is primarily known. So depending on how I think about some of those ideas, it's going to affect how I look at the world and ultimately what I think is important and the values and choices that I make in response to that view of the world. So again, that's broader than just culture. Culture includes worldview, but I can be a part of a specific culture and at the same time have different ideas in my worldview than other people in my culture. So part of the importance of worldview is to be thinking about what is this person's individual worldview and what is it made of, which may include cultural aspects, whether that be being an American or being from a particular ethnic group or another subculture. But again, a worldview is broader than that, and it's really about some of those core answers. So a worldview approach recognizes that both clients and clinicians bring a worldview, again, not just a specific culture, and that awareness and assessment are vital for engagement. So if I'm not thinking about kind of how you're and some of your fundamental ways of thinking about and answering these questions, then I'm not going to be able to know where we're different or where we're the same or what kind of challenges that might bring to the kind of interventions or theories or ways of helping you that are important. So a worldview approach seeks to acknowledge and navigate worldview factors toward optimal outcomes. So I want to be able to come alongside and understand and then navigate how to work with that worldview, both yours and mine, in that process of change. So a worldview approach acknowledges and assesses, again, someone's underlying beliefs and assumptions and their relevance to theories of change held by the clinician and the client that are going to impact interventions and processes and outcomes. So again, if you come into my practice and have a worldview that says, I don't believe that my thoughts matter in terms of how it affects my life, and I'm a clinician who wants to use cognitive behavioral therapy, then we're going to have a problem, right? Automatically, we're going to have some different worldviews on that. And so we want to talk about kind of what that process looks like in terms of designing interventions. A worldview approach recognizes that beliefs and assumptions include a person's thoughts and their ideas, as well as what you might call feeling concepts. So when a person comes into care or treatment, they have thoughts about how the world works, they have ideas about how the world works, but they also just kind of have some gut level reactions and assumptions about how the world works that they might not be able to articulate as clearly in some kind of statement or idea that they can express. But they're still all at play in terms of how they're thinking about and filtering the world, including their interaction with us as helpers. So broadly speaking, worldviews speak to underlying assumptions and beliefs regarding values and morals, whether they're derived from human beings and culture or some transcendent source. So again, if you're a person of faith, then your worldview is going to include that values and morals are connected to that faith system. If you're not, or you have some other worldview that doesn't include God, then where do those values and morals come from? Those are going to be connected to those ideas that you have. What sources of authority are assumed, and what are the implications? So if I believe in God, I'm going to assume that God is a source of authority or a particular religious book. If I don't have a strong faith, then where am I getting my ideas about what's true and from? Whether it's partly from myself, from politics, from some other source of authority, books that I like, people form their ideas for reasons that are based on authority. Maybe it's the cultural authority that they're from. Worldviews also include ideas, again, of what it means to be human, including the meaning, value, priorities, and purpose of life, relationships, sexuality, work, ethnicity. And again, those might be more than just the culture that they're coming from. They also speak to issues of authority, power, and responsibility, and their purpose, place, and use. So in the clinical world, we might think of some of that in terms of internal and external locus of control. So where do I think the power to change comes from? Where do I think how much power do I have versus how much I'm affected by the world around me or other things? And those can be important aspects of how you engage somebody in treatment and seek to help them and the kind of interventions that you design. What's the purpose of life, of activity, of relationships? Those are going to matter in terms of how the choices that people make. And then destiny and future. What constitutes a vision of destiny and a better life for the future, depending on how clients see that, or even how the theories we're using see that, is going to affect our treatment interventions and approaches. So as we talk through, again, these worldview issues and even theories of change in a few minutes, try to be thinking about it on those two levels. One, you have your own worldview and you have your own assumptions about these ideas. You're going to have a client that has their own assumptions and background operating system going on around these ideas. And you're also going to be choosing theories of change that have their own assumptions about how the world works and how change works. And so that's why we're trying to kind of bring those things together and say what's going to fit in this situation and how we're going to work on change together. So a worldview gives us a view of the world. It's, again, our underlying explanation, assumptions, and fundamental beliefs about reality, including origins, identity, meaning, morality, and destiny, as we just discussed. A worldview provides the framework by which people make sense of what happens in the world. So our worldview shapes our emotional responses and interpretations of events, information, data, and even our code of ethics. If you're a clinician, it's our primary lens and filter. So people react to the world around them based on their worldview. They also interact with the world around them based on their worldview. And it's often more caught than taught. So there are ideas that we believe because we've been very clearly taught them, or they were parts of our family, or parts of ideas, or again, sources of authority that we've bought into. But oftentimes they're just caught. We're swimming in the water of whatever that culture is that we're part of, and we're also absorbing some of that along the way. And it's developed and informed by impulses, experiences, and knowledge. So some of you might be familiar with Jonathan Haidt's book, The Righteous Mind, that came out a few years ago. Part of his research is just emphasizing that often what people do is we're not as rational as we think we are. We tend to have certain impulses and then rationalize and justify them versus having ideas that shape our impulses. And that's often true for our clients, of course, as well. Our worldview determines our view for the world as well. And again, it shapes our values and priorities, which then affect our behaviors and choices. So if we or our clients do not reflect on and examine our worldview and what we believe, we will simply adopt or absorb a worldview or the ideas around us without critically examining their validity, usefulness, or impact on life, choices, and outcomes. Ideas and beliefs have consequences. So that's why this is kind of the foundation of this process, not only for the therapy interaction, but to really think about in our people helping world is our ideas have consequences, whether for good or for bad. And so we want to really be thinking through what are those underlying values and beliefs and core assumptions that are being made by ourselves, by our clients, and by the theories and interventions that we're working with to bring those together. So what we're really asking is this, again, when we're thinking about a theory in particular, we're asking what is the origin story, assumed starting point, or ideal state of the world according to that worldview. And that might be for your client as well. And so I could ask the client, what do you think a perfect or better world or life would look like, or maybe look like for you, and why? If you ask that question, you're going to get a little picture of what they're assuming about kind of the ideal state for them is, or and that's important because maybe they'll say something grand and glorious. Maybe they'll say, well, you know, I don't think I'll ever be more than what I am, but it helps you to understand kind of what their current assumptions are about the future and how they see that and what's important. What does it assume about what people are, their place, and what they are for? Again, that's going to matter in terms of how I see my life and what the value of my life and what I'm going to be about. So I could ask my client, you know, what is most important to you? What do you currently think of as your purpose, or where you find most meaning in life, and why? So again, you can see these are different questions than just asking about someone's culture. I can know some things about someone's culture. That doesn't necessarily tell me that that's what they really believe or how they look at the world or what's important to them. We're all from a certain culture or ethnic background, but you might not agree with some of it, or you might not, some of it might not be the same for you as it is for someone else in your family. And so a worldview perspective says, I want to understand your particular framework and understanding on a deeper level, not just cultural things. So what does it assume the problem is? What went wrong? Why do suffering, evil, or certain symptoms or problems exist for the individual or more broadly? So again, for the client, I might say, how do you see the problems that you have? What are their causes in your view at this time? What do you think the main problem with the world or your world is in general? Again, these help you to get an understanding of where that client's coming from, how, again, they see the problem. Do they think it's a medical problem? Do they think there's other factors? Do they think it's their job, their spouse, some other component of their life? But that's going to tell you something important about how they're looking at the world right now and what some of their assumptions are. And then lastly, what is the solution to the problem? What hope or vision is there? And does it fit reality? So again, I could ask a client, what do you think would make things better? If you were giving someone advice on how to change a problem like yours, what would it be? What do you think it takes for someone to have a better life? And why? Again, this will help you to understand what they think currently about change and how that works, or what they think is important when it comes to solving problems, to know better kind of where you're starting from with that particular person. But these are all the same questions that you can ask of yourself when you think about how you look at the world. And you can also ask them about any theory or intervention that you're considering using, because they all come with these same ideas. So I wanted to use Maslow's hierarchy of needs as an example of this. Hopefully all of you are familiar with this. This is kind of a very introductory model that most of us see in school or in working with in helping professions. So you can see it in front of you. It's this basic idea that we all have basic different needs at different levels kind of who we are, starting with the bottom of physiological needs, and then safety needs, needs for belonging and love, esteem, cognitive needs, aesthetic needs, self-actualization, and then finally this idea of somehow being transcendent or growing to this place where we have this high level of maturity and understanding. So the model itself, for one, assumes certain things when you think about what its worldview is, and we're going to talk a little bit more about that. And it's just one example of every theory. Again, every model comes with certain assumptions, worldview assumptions behind it that then drive how we might respond to somebody. So this model assumes certain things as well. So if I was asking these questions about Maslow's hierarchy of needs, I would ask myself, what's the origin here? What's the ideal state it implies was lost? So in thinking about that model, it looks like, well, the ideal state is if we can reach this state of transcendence, and that there's all these potential barriers or challenges to getting to that final layer. And so somehow if I don't have those underlying things met well enough, that I'm never going to reach that state, right? So that's kind of what it's assuming, the picture that it's painting. The question is that true? Is it really true that if people don't have enough of their physiological needs met, that they can't reach any kind of higher levels of thinking or spiritual maturity? I don't think so, but that's what the model tends to imply, right? Does that mean that there's people in poverty-stricken countries who aren't smart or who haven't reached levels of spiritual understanding? Probably not. But is there some truth there that, our physical and safety needs can get in the way? Of course, right? But it's important that we understand that, again, there are these certain assumptions, and if I take them very literally, then it's going to lead to certain things. So what is the problem? Again, the problem is defined as not having enough of those lower needs met sufficiently, and that if somehow they're just met, then everything will be well. What does it assume about human beings, what they're for, and how they're put together? Well, certainly assumes that we have these multiple layers of who we are, which is true. We have physical, relational, spiritual, emotional components of ourselves. What is the solution or solutions it proposes? Again, it proposes that if these needs are met adequately at each level, then we'll kind of build on them step by step and we can get to these higher levels. So it's more of a step-by-step kind of view of the world. What is the destiny it assumes or imagines? Again, we've talked about that it's to lead us to this higher level. What actions does it imply should be taken? That we should focus on meeting lower needs first. And then finally, is it true that there is a hierarchy? Does it really work this way? So again, it's not to say that this is a model that has no value, but like with all models, asking those worldview questions and really assessing it and saying, okay, does this fit reality? To what degree is this true? What evidence is there to support it? Is important in thinking about whether this represents an intervention or a strategy, and to what degree that I might use it with a client. So here's some other important aspects of worldview. Again, they all include assumptions about power. Where does power or the power to change come from? Who or what has control and how much? Therefore, what should be done? And what does this mean about change and an individual's or community part in it? Again, if I assume that I have a lot of power to change and that I have a lot of ability to make my life better, that's going to be a very different way of approaching life than if I assume that I'm relatively helpless or don't have a lot of power, or that other people have a lot of power, and that I'm primarily a victim of it or whatever. That's going to affect my interventions and my choices of change, as well as how I might go about change in my own life. Truth. What is truth according to the theory or perspective? Where does truth come from? What does truth mean for decisions regarding human relationships, change, and morality? I don't know what Maslow would say. It's not clear, but what it is clearly saying, again, is that there's a certain perspective on human beings that it believes is true. And those ideas about kind of how we approach where to get truth, whether it's from science or religion or other things, affect, again, kind of where we're going to go for the answers, right? And so knowing kind of how a client sees that is also important. Freedom, another aspect of thinking about worldview is how does it look at freedom? What is freedom according to the theory or to that person? Is it freedom to be who we want to be or feel we are, or who we were made to be? Who gets to decide how much freedom someone has? Is it freedom to something or freedom from something? Does freedom imply autonomy, or is it freedom within limits? So again, if I have a client who says, well, I'm going to do whatever I want, and I don't care, they're telling you something about their ideas about freedom and whether there's limits to it, and that's certainly going to have an impact on what they do or don't do in the process of trying to work with them. Even ideas like love. What is love? What is loving? When is love accepting and tolerant or affirming? Or when does it include truth, limits, and boundaries? So how a client views those things, how I view those things as a clinician, is going to matter in terms of how I assume change works and what theories and what ideas and what boundaries become important to that process. So these underlying definitions of things and terminology and beliefs about these ideas very much affect client outcomes and choices of interventions and strategies. And then process. What theory of change does the worldview assume or lead to based on its assumptions and answers? So depending on how I answer those questions, the definitions I give to those words, it also affects how things are going to move forward. A question of worldview process is how long should change take? So if I'm looking at Maslow's hierarchy again, it's unclear, but it looks like it could take a long time because I've got lots of steps to go through before I can get to those higher levels. Also, what outcomes should be expected? Again, with Maslow, it looks like I can only expect to get to the next level once I adequately take care of the lower levels. So that tells me something about the outcomes I should expect. If I'm working with a client and they're really struggling with just getting basic physical needs met, does that mean that I should never expect outcomes in terms of their ways of thinking about something or their relationships or things at a higher level? What factors are assumed to be involved and most important to achieving the improved outcomes? And all, again, theories of change will tell you something about what is most important in that process. So as we've said, all worldviews are rooted in sources of assumed authority or truth. So part of the question is, what are those assumed authority sources or sources of truth? Is there evidence to support them? Worldview beliefs and assumptions guide our strategies and choices for clients and clinicians based on worldview definitions and ideas of what things like well-being mean, what the good is, what healthy means, and how they are prioritized. So that's another great question that we should be asking ourselves, maybe even our agencies or when we think about our theories, but even our clients is, how would you define well-being from your perspective? What does being good in life look like, or what does a good life look like? What does healthy mean to you? What would healthy look like for you? Those are really important questions because they tell you, again, something about the values and priorities and assumptions that that person or that theory or that you're making as you work with a client. So worldview lenses shape our practice, our client engagement, and our effectiveness as practitioners. What we assume as clinicians and our answers to worldview questions shape our beliefs, what we advocate for, and the theories and interventions we prefer, which impact results for clients and families and communities. Our preferred theories also shape our worldview. So we'll talk about that in a minute. Outcomes are also connected to how well we engage and come alongside the client's worldview in helping them to explore, evaluate, and implement effective strategies and ideas that lead to change. So every relationship is going to involve two people with two different worldviews engaging with each other, and some of them might be similar and some of them might be more far apart. But in order to work effectively with somebody and walk through a process of change with them, that's what I'm navigating at all times, which is why that's the important foundation. So this is just a brief summary here. Again, a worldview assumptions plus epistemology, which is what is truth and how we know it, equals assumed definitions and understandings of problems and their solutions, which is what a theory of change is. Okay. Before I just jump in with any questions you have for a second, let me this for a second. So one of the handouts that I think Kristen sent you should look like this. So this is kind of an overview of what we're talking about in terms of the process of designing effective change. So you can see at the bottom where it says understanding worldview and defining truth. That's where we've been talking about at this point. And as we move up the ladder in terms of thinking about designing effective interventions and processes for change, the next one is identifying and operating from a theory of change, which is rooted in our worldview. So that's why we started with that. So hopefully that makes sense. So let me just stop and see if you have any questions so far about the worldview piece before we move on. All right. So the next component, again, of our ladder is identifying and operating from a theory of change. Just some things that you might commonly hear in terms of the struggle we all have with change and how that works. Why are people like the weather? Because nothing can be done to change either one of them. Or how many social workers or whatever you are, clinician, does it take to change a light bulb? One, but the light bulb really has to want to change, right? So these are kind of some old ideas or jokes we make about change that, we can't help anybody unless they really want it. And again, there's obviously some components of truth here, but our theory of change affects our client engagement and motivation. So if I really believe that, if I really believe that people only change when they really want to, there might be a lot of clients I never see because they're not quite ready for change at the level that maybe I think they should be. Okay. So what are theories of change? So a theory of change is your overarching theory, assumptions, and guiding understandings and beliefs, whether in general or specific to a client, about what you assume that change process should entail or what it looks like, and the presuppositions that you have. So on a broader level, that means that, again, I have certain ideas about what I think is important to the process of change for everybody. But maybe you walk into the room as my client, and based on the story you tell me, or your appearance, or your culture, or your struggles or behaviors, I make some assumptions right away about what I think change needs to look like for you. And most clinical people do that. They have some automatic reactions and assumptions, which is why we want to be really careful to think about it and make sure that it's aligning well. A theory of change helps clinicians know what they are doing and why. It enables them to develop a clear framework for monitoring and evaluation, a more common understanding, clarity, and effectiveness in their approach. So the more aware we are of kind of the tools we're using and why we're using them, and how we're going about engaging with somebody, and the more effective we can be. A benefit of theories of change is that they may also be subjected to modifications to incorporate ongoing processes of reflection in the process of exploring change and how these happen. So again, whatever theory of change I might decide is important at the beginning in working with a client is open to some change and modification as new information comes, and I understand the person better or understand where they're at better. And good clinical work and designing good interventions always involves that ongoing processes and shouldn't be too static, even when implementing an evidence-based practice. Like if we're too rigid, in my view, in terms of trying to force people into certain protocols or boxes, we can get into trouble even when we mean well. So it doesn't mean we can't follow protocols, but I think we just need to be aware and open to some of those differences. Theories of change reflect those underlying worldviews we were talking about. The theories of change we use the most reflect our underlying worldview and beliefs and personal felt experiences with change. So oftentimes the things that we think are going to work best for other people are the things that work best for us, right? Our personal emotional reaction or experience with something in the past that's saying, hey, this is what's most important. And our underlying worldview assumptions will continue to reinforce our choices of theories of change, because those are the things that we believe the most. So exploring theories of change, questions to ask yourself, or maybe even a client. What do you think are the key ingredients to overcoming bad habits, painful emotions, or personal problems? What do you automatically tend to think or assume, and why? Again, so if a friend came up to you and said, you know, I've got this problem with smoking or something, what would be your automatic reaction to what they should do to stop smoking? That's going to tell you something about your assumptions about your theories of change and what's important. What clinical or practice theories have you been taught or have most shaped your view and approach? So again, if you're a clinician like me, whether you're a social worker or a counselor or a marriage and family therapist, or maybe you're a nurse, you're going to have some theories and things that you were taught and perspectives that had, again, worldviews behind them that said, hey, these are the most important and here's why. And they have something to do with how change works that we should think about. Or if you had to boil it down to one most important thing when it comes to bringing about change in a person's life or your own life, what would it be? And then why do you believe this? So these, again, are questions that we can ask ourselves or clients, again, to help clarify what some of their understandings, assumptions, and beliefs are about change and how it works. Here's just a list of theories that we often use, again, in mental health world anyway: cognitive, behavioral, psychodynamic, social learning, medical model, client-centered, cultural competence, strength-based, trauma-informed, family systems, ecological, stages of change, developmental. Politically, we have capitalism, socialism, communism. All of these represent ideas about change and theories about what works best and what kind of processes result in the best outcomes. So as you can see, this is just one list. It's kind of a major list of things that we often rely on in mental health, at least, but there's more. So there's a whole lot of kind of theories of change and worldview assumptions potentially coming in to play whenever we're trying to design effective interventions. So what do you and possibly your client assume or prioritize as key factors when thinking about causes and solutions to problems? And why do we assume them? Is it based on one of those theories? Is it more than one? If you use those theories, which do you tend to prioritize and why? What sources of authority do you prioritize in evaluating your preferred theory? What perspectives, beliefs, and priorities do your clients bring? So, and here's some key questions that I think clinicians need to ask themselves. If a client doesn't readily agree with my preferred theory or model, are they considered non-compliant? Or does my theory mean that they are more likely to receive a certain diagnosis? So as you can see, again, if I'm too rigid or too bought into a certain theory of change, it could mean that I treat a client negatively or have a negative attitude toward a client. Well, they're just being non-compliant because they're not agreeing with my particular view or theory of change right now. Or based on my theory of change, you tend to get this diagnosis from me more than another. We have to be careful with those things. Even the DSM-5 represents a theory of change that there's some assumptions behind. What might this mean for your ability to effectively engage or work with a client? That's something we need to think through. So most clinicians consider themselves eclectic, which means that they draw on a variety of theories, which is fine. But again, part of the question we have to ask ourselves is, what does this mean? What does it mean for me when I say I'm eclectic? What worldview assumptions does that imply? Does that mean that I believe in nothing? Does it believe that I prioritize certain theories over others? We have to even understand what we mean by that. All clinicians value and prioritize some theories, values, or ideas over others. That's just normal. And even our codes of ethics drive certain theory choices and strategies for us along the way. So how can we best evaluate, select, and apply specific theories of change with clients to meet them where they are, while also pursuing better outcomes? So back to our model that I showed you. Again, we started with the worldview section, and we got to the change section to start to reflect on how worldviews connect with different theories that we've learned or that we've been taught or that our agencies promote in terms of working with clients. Okay, so the next kind of handout I'm just gonna kind of walk through with you is the tree handout that Kristen also sent. And this is a way of just looking at people as a whole or ourselves as a whole and how change works on a bigger picture level as we start to think about how different theories might connect with that and how to work with them depending on the needs or place of the client. So the first one we want to think about, I'll pull that up in a minute and walk through it with you. But so for me, I always think about starting with the fruit. So whenever a client comes into my office or they're coming with certain fruit that they're struggling with, it could be emotional, could be behavioral, could be relational, could be mental in terms of some of their mental struggles. If they have a serious mental illness and they're struggling with their thoughts. But this is all kind of fruit in their life that they are bringing to the situation that they're struggling with. And that's usually what brings them and that they have been trying to manage or figure out how to change. And so when people come into an office or to an agency, they've usually tried to do some things about it before they got there. So we have to think about how do people normally go about trying to change the problem fruit in their lives? What do people usually think the reason is they are acting or feeling a certain way? And if the client were answering the question, if only blank would change, then I would be fine, what would that be? So again, that tells me kind of where the client is starting from. But it's easy to focus on fruit, right? So, and what we think of that in terms of clinical work is that sometimes we just have to do symptom management, right? So whatever that fruit might be that's causing struggle or problem in my life, sometimes it's something that has to be managed or try to just reduce it because of the problems it's causing. But it's not necessarily the actual cause, it's just the fruit. So the problem with fruit, when you think about a tree, is that we cannot directly control it or change it. So I might be able to help manage it, but I can't really directly change it or make it go away on its in a direct way. It's being produced by the tree and its processes. So I can't say to an apple tree, tomorrow I want you to be a peach tree. Or I can't say to an unhealthy tree, tomorrow I want you to produce healthy apples, right? The tree has to go through certain processes of change in order for that better fruit to be produced. So to have a healthy tree with healthy fruit, certain things are going to be required. And so this means something in terms of how we think about things as clinicians and the interventions that we select, and maybe even in what order and priority when working with people. So this is where I'm going to pull up the tree itself so we can look at that together. All right, so it's easier just to kind of walk through this together as a picture, and hopefully also makes more sense as a picture. So what we were just talking about here is the fruit. And as you can see, we can have clients who come in to care with emotional fruit issues, maybe anger, guilt, depression, anxiety, fear, emotional instability, other problems with desires or wanting negative things. Could be behavioral fruit, again, things we do or say in response to that internal state, whether it's things that are said, behaviors, actions, habits. It can be compulsions, addictions, relationship problems, communication problems, sexual behaviors, hurtful habits, controlling behavior, criminal stuff, aggression, self-harm, maybe even mental fantasies, escapes, things like that. So these are behaviors, these are symptoms that are kind of coming out of my tree. And if I think about it narrowly, then I might automatically just pick an intervention and say, oh, well, I need to pick an intervention that focuses on compulsions. And what is that one intervention? And that might have some value, but I'm still not kind of thinking about the person more holistically, and all the ways, all the things that might be happening that are helping to create that fruit in their life. So I might need to do some things to help that person, like if they have depression, medication is one way of helping to manage that symptom. But it's not actually fixing depression per se. It's probably just helping my brain to feel less depressed and not the reasons why it's getting depressed for other components of my tree. So what I usually do then is just step back and say, what do people then mostly focus on when they come in with that fruit? What if they were usually saying, what's the cause of that problem? Oftentimes people will say, well, it's something in my branches. So the branches of a tree represent kind of our current world that we're living in, whether that's our relationships, marriages, children, jobs, communities that we're a part of, other organizations, resources and supports that are available, whether they're abundant or whether they're lacking. That's kind of our current world. And so, of course, they matter. But oftentimes people might come in and say, well, I'm depressed because, my kids are having problems. Okay, again, I would never say that wasn't a trigger or cause of their depression, but it might not be the only one, right? And so we have to really then say what's going on potentially in other things. Is it just this one thing in their current world that's triggering it? Often we would call that, as clinicians, we'd say, well, they're having an adjustment disorder. There's something in their world that's popped up in the last period of time that's really the main cause. And when that thing goes away or gets better, things will be okay. So that would drive some treatment choices and interventions on my behalf in terms of what I might do about that to help that client if that was my conclusion, that it was the main cause of the negative fruit. But oftentimes it's more than that. And so we also have to step back and look at the tree as a whole. So then I kind of skip down to the bottom here for a minute and say, how do people work, so to speak? Well, the way people work is that we're all born into a certain soil that we don't get to choose. And that soil can include a lot of different things, both biological and genetic, as well as environmental, cultural, and even spiritual, the things around us that we didn't get to choose, but that impact who we are and our development. And so you can see there's a list of things there at the bottom that are kind of potentially part of that mix of soil that we get planted into, and that we then kind of have to grow within. That's the soil that we're growing within. And it can be, anywhere from very positive to very negative or some combination in between. And nobody's soil is perfect. So everybody's got something along the way that comes into play. And we interact and respond and grow in the context of that soil. And so maybe there's some things down in that person's soil that were really painful or impactful or that helped shape who they are, whether they're genetic things or whether they're environmental things that impacted them, that could be something that really needs to be considered. And then we have kind of our roots. And so you think about the roots in terms of emotional roots. So all of that growth and development as a person, and how I see myself and how I feel about the world and feel about myself is happening in the context of that soil. And if there's hurtful, painful things, abuse or neglect or chronic stress, or maybe even just bullying at school or other significant events that sometimes we experience, can result in deep feelings of rejection or disapproval or emotional wounds and insecurities that get created, sense of low self-worth, or maybe feelings of jealousy or fears, or unhealed kind of pain from my past, or maybe a deep sense of injustice for something occurred, or lacking a sense of competence in myself. Maybe I have bitterness over those things, or shame, or have felt like a victim, right? So if those are things that have happened to me emotionally, and I have these unresolved emotional wounds in my past, then those are going to be infecting my tree, right? And they're going to be part of why I may struggle with depression now. But I'm probably not thinking about it, or a lot of people aren't thinking about it because it's underground. My roots are still underground, and I might think, well, that was a long time ago, and that shouldn't affect me now. But that growth process in terms of what I didn't choose in my soil and my roots and some of the hurts that I may have experienced are all kind of working together in terms of how I see myself and my identity, the choices that I'm making, maybe ways that I'm interacting with others due to trauma or other things in my personality and my relationships. So all of that is kind of growing over time and interacting over time. And the trunk of the tree is back to kind of our idea about the world view, that the trunk represents things that I can ask you about. What do you think? What do you believe? How do you feel? Above ground things, but it still represents that worldview stuff of internal beliefs, thoughts, vows, attitudes, filters, perceptions, that have all kind of grown out of this soil that I've absorbed, or that I've reacted to, in terms of how I think about myself and the world and life and relationships and what I assume. So as all of that plays out, in the above world, things happen in my branches and in my current world that trigger that. And my whole tree is kind of at play, right? And my whole tree is producing that fruit. So when we think about a theory of change, this in and of itself is a theory of change that says we are whole people and that there's a process involved in why fruit gets produced in a certain way. And the question then becomes, which parts of the tree need help? What interventions and what theories and which ways of engaging this situation are needed to help this tree produce better fruit? Again, sometimes it might be one particular area that's the most important. Sometimes might be more than one. Sometimes I might have a tree that just needs some pruning and tweaking for the time being. And sometimes you might be working with somebody with a tree that's got some really bad soil and damaged roots and even some very real struggles in their current branches and current world. And there's kind of all kinds of significant or severe fruit that's being produced and requiring a lot of different types of tools and strategies and interventions. But it's important that we understand somebody's tree in this way in order to best choose what theories or interventions make the most sense overall, but also where to even start and where that person is capable of starting. Because as a clinician, just because I think a certain theory or approach is what you need doesn't mean you're ready to jump in and do it, right? So we're kind of making those decisions along the way as well. All right, so this is kind of what we just walked through in our visual picture to help you understand. So again, the idea is that to produce good fruit, trees need specific things. So we might need to look at what does this particular tree need in its soil, its current soil, to help this person to grow and produce better fruit. Thinking about trees, we want to make sure that they're getting regular water and sun, that they can develop healthy roots, that their trunk is solid, and they have strong branches. That's what's going to create the healthiest tree. So thinking about that as a metaphor for how people are, again, I want to help them have work with that soil if they had negative soil in their past, help them resolve some of those things that might be continuing to feed their pain or their struggle, helping them to learn new things about relationships and maybe boundaries or how those things work, gain better experiences, begin to think differently at the level of their trunk, help resolve some of the issues in their current life to reduce their stress. So I can intervene at multiple levels of someone's tree, and often I have to or need to in order for that to actually help them produce the kind of fruit, more of the kind of fruit that they're desiring. So obviously the idea is to not oversimplify kind of our approach to helping bring change into someone's life. So treatment design is informed by my assessment, and the particular theories that I'm choosing to go along with that or that I'm recommending, the client's participation and willingness to engage in that, and my own expertise and practice wisdom. And the process is going to be dynamic and interactive, and even include what stage of change that person is at. So again, if somebody comes in and I often share the tree with people in terms of kind of helping them to understand themselves, but maybe they look at it and they go, well, I'm not ready. I don't want to change this part of my fruit, or I'm not interested in dealing with this. Okay. So stages of change says I want to meet that person where they're at and they're not ready yet to deal with that. But that doesn't mean I ignore it altogether. So maybe I can work with that person over time and explore some of their barriers and challenges to wanting to address something. And over time, they become more motivated and more ready to go about changing things that they weren't initially willing to change as I work with them in their tree. Okay, so those are the foundational kind of components of designing effective strategies. Then we're going to move on to that next level of our picture in terms of the process, and that is maximizing clinical competencies and context. So I might have great theories, I might have good worldview interaction, and we're designing good things, and I'm not a good clinician. I don't work well with people, or I don't engage well in terms of creating a climate and bringing some of that together. So I'm probably not going to get as much good outcomes with my clients, right? I can have all the head knowledge, I can have great analysis skills, and I can have not good bedside manner, right? Just like your doctor, might be really smart, but maybe he's not so good at engaging with you well. So we want to be thinking about what are those clinical competencies and what kind of context is important to good outcomes. And those include things like that we call common factors. So there are certain things that are above and beyond the theories that we use that are important to good clinical outcomes. That includes the skill of the clinician, again, to utilize the things we were just talking about or to relate to people. It includes that person's level of expertise and their attitude. It certainly does still include the client's level of motivation. But I don't think it's not the only thing. It includes the engagement and the rapport and relationship that we're able to establish. It includes even advocacy for other resources and other things to help come alongside you and produce better outcomes. And then obviously just other external factors and supports that might be completely out of my control as a clinician. There are certainly things that come along in people's lives or pressures or family situations or cultural contexts that are more powerful sometimes than what a clinician or an intervention is able to overcome, at least quickly. So those are part of the common factors that affect all treatment, but a lot of them are still within our control and ability to improve that as we work with people. Other things that are important in terms of common factors are the ability to instill hope and positive expectations in someone for change and for their ability to change. Creating a positive alliance. If it's a group therapy situation, the ability to help establish cohesion in a group and have people build good relationships with each other. Empathy and collecting client feedback and kind of engaging them in the process have been shown to contribute to the effectiveness of outcomes. Some other things that are probably effective, according to the research, ability to reach some consensus around goals. But again, I don't think that's always necessary, at least initially. Like, we might not agree exactly on the goals, but that doesn't mean we can't continue to work together over time and clarify what those are or where we're going. People don't always know what their goal is very clearly at the beginning of anything. Sometimes we have to work with them a while to do that. Collaboration, again, ability to collaborate with somebody and have them be a part of that process. And positive regard for the client. Again, if I have a negative view of somebody, it's going to leak out, and they're probably going to sense that, and that's going to impact the care and process. And promising as effective are things like congruence, genuineness, emotional intelligence of the therapist, repairing any alliances if there are problems in the relationship between client and therapist over time, and then managing counter-transference. Again, if a clinician gets personally involved or has their own issues triggered and doesn't manage that well, then that's going to affect the outcomes of the care. So this is just a little overview included in your slides, again, of some of those things we talked about, but based on some of the research around what is important in terms of common factors. So in addition to those common factors, just on the clinical level, I wanted to also point out on a higher level some of the things that are important. So when I was working in a community mental health center and around with kids with challenging and severe emotional disturbances, one of the things we tried to do was just create a culture of a context where, how can we get the best outcomes with children and families? What is it going to take in terms of how clinicians view clients and how they see their work in order to really, again, drive change and a positive view of where we can get people to go, and not be negative toward them and not create unhelpful or unhealthy interactions. So some of those things included just a dedication to positive client outcomes as an overarching goal, regardless of the specific theory or intervention. So there is research, again, that shows that no matter which intervention you choose, if you have a positive outcome about it and believe in it, that people are more likely to buy into it, and therefore it'll have better outcomes. So it's not just about always the technical aspects. It's about, whether the client believes in it and buys into the fact that it is helpful. A relentless belief in and pursuit of client success. So again, that idea that we believe in you and we believe in your success, and we're here with you and we're not giving up. When people approach things that way, much more likely to get clients who also then feel encouraged and have hope and are more able to continue to work toward change. And then a commitment to caring and to excellence, letting people know that we genuinely care about you in an appropriate professional way, but we genuinely care about you. You're not just another number, and we're here, again, trying to do excellent work to help you achieve change in your life. So some of the ways we kind of articulated that in terms of our values at the agency was to say, we recognize that we can't help clients if we don't effectively engage them and take full responsibility for making this a top priority. So instead of saying, the client didn't show up, or the client had this, the client's irritating me somehow, and therefore I'm not going to work at engaging them. We tried to call people higher and say, no, it's our responsibility What are we doing what can we do different? What can we do better? How can we engage this person better? Maybe it won't work, but we're going to take responsibility first and not just blame our clients. We're going to strive to be warm and welcoming to all the clients we serve, believing that clients won't care how much we know until they know that we care. So again, we're going to place an emphasis on demonstrating caring attitudes toward people, regardless of the struggles or problems that they bring. We're going to operate again with a mental model that recognizes stages of change, that not everybody's at the same place in terms of their motivation, taking people where they are and designing interventions and approaches to match the stage with what we're proposing and the strategy for change. I don't want to get too far ahead of the client, so to speak, because they're just going to get freaked out or overwhelmed and run away, right? So how do I meet you where you are and design my intervention strategies at that level, even if I know that I want to take you somewhere farther along the way? Taking a strength-based approach in view and avoiding being judgmental, labeling and identifying clients as non-compliant, resistant, borderline, etc. Sometimes clinicians do this to people or get caught in doing this to people. And so it was one of our commitments. Hey, we're not going to do that. We're not going to use those words unless they're actually true. And we are not going to be judgmental. We're going to understand that people have reasons. We may not agree with their reasons, but we're going to try to understand those reasons and meet them where they're at, which is the next line. Assume everyone has their reasons for being where they are and seek to understand the client's journey, including past trauma, emotional injuries, and fears, including with past therapists or the system of healthcare, because sometimes people have negative experiences there that impact their willingness to change or ability to engage in change. And then we're going to examine ourselves and our own reasons for resistance and frustration with clients when they arise and look at how we can better engage them or work that through. So just clinicians taking more responsibility for their own values and how they're working with people can really make a difference in terms of outcomes for clients. We also had certain commitments that we wanted to work on. So our commitments were effective collaboration, seeking to partner effectively with clients, coworkers, and the community to be honest, open, respectful, strength-based, and empathic in our communication. A commitment to clinical excellence to provide excellent, effective, and timely services to clients and be accountable to them and each other for high-quality work that gets positive results. So I had a high standards and high vision toward what we wanted to be able to do. Personal integrity, conducting ourselves with fairness and honor, seeking to always do the right thing and remain client and solution focused. And again, genuine care to provide client-specific and outcome-driven care through our dedication to strengths-based treatment, encouraging client voice and choice, understanding of each client's unique needs, and persistent pursuit of engagement that demonstrates our sincere concern, care, belief in, and support of the clients we serve. So these were kind of our mantras. And so we just kept calling each other back to, hey, this is what we do. No matter how hard things get, we keep doing this and we keep working toward good outcomes for people. Okay, so the last piece here of our clinical strategy as we've moved up that ladder is we've got our worldview foundations, we've got our theories of change that we're having to think carefully about and which ones to select based on that person's tree and where they're at. We want to make sure that we're operating with our common factors and learning those softer skills and abilities well as we move up that ladder. And then as we do that, we're choosing evidence-informed interventions that best fit kind of that whole scenario. I don't want to take the time to pull this up again. You can see it in front of you. I'll pull it up again at the end. But so our clinical decision-making process, that's where we're at kind of on the ladder. So finally, we kind of have to remember that we're choosing evidence-informed interventions and that choosing them is a process. So sometimes in the clinical world, we get caught thinking that evidence-based practices are these things that come in a box or certain protocols, and that that's what it means to do evidence-based practice. Historically, what evidence-based practice meant was that it was also a process of choosing the right interventions for the right clients, not just a prefabbed model that, again, got implemented. Again, those can be good and helpful, but how they get implemented is also important. So just because it's evidence-based does not mean that it's the best fit or timing for the client. So we need to think that through well. So here's kind of what evidence-informed interventions looked like in terms of a process. It's getting the information we need relative to whatever, again, is going on with that person's tree, and kind of asking, what's the question? What's the problem we're trying to solve here? So again, if I'm looking at that client's tree and saying, well, the priority seems to be really trying to solve the issue of whatever's happening in their marriage, or maybe it's what's happening in terms of their thought life. What evidence-based practices will best fit that particular problem is one part of the question. But the other part of the question is does that practice align well, again, with this client's current worldview and their stage of change, right? So even if it's a great evidence-based practice that seems to align with their biggest problem, are they ready for it? Are they going to be able to engage with it? Are there worldview issues that are going to undermine it? Where do I need to kind of start that process before we get there, even if that's where I'm trying to head? But then I track down the best evidence of what might work best. And given that entire context, I appraise the evidence for its validity and its impact and its usefulness. And then I choose a practice, again, that will fit best to that situation and timing. And then even as I'm doing that, how do I evaluate whether it's effective and most helpful? So in social work, we have this saying that says, evidence-based practice and practice-based evidence. So it's kind of a circle, right? I can choose evidence-based practices, but I'm also needing to use information from my practice with you and the evidence that's coming out of whether this is working or not, to continually evaluate how effective things are. And I think about that as practice wisdom, that it's this combination of both evidence-based practice and practice-based evidence, and the wisdom that I gain over time by working with people that helps me really make those decisions. And then lastly, again, as we're doing this work, as was said, identifying and monitoring outcomes are really important to know whether or not we're actually getting the results. And those could be things I'm monitoring in specific to a client, or it might be on an agency level. But again, am I measuring symptoms or am I measuring functioning? That's always a valuable question. How do I really know whether somebody's less depressed or not? You could have a bad day when you come into my office. Is that really what I want to do to measure your depression? Should I be using, again, a tool of some kind to measure that more consistently? Or do I want to measure your functioning? So even if you still struggle with some depression, but you're functioning better, you have a job now, maybe that's a better way to measure it. So thinking about tools that really help us to define success better, define our goals well. Am I measuring outcomes versus services? Sometimes agencies or clinicians like to measure services. Well, you're getting better because I saw you 3 times this week. That's not telling me whether you're getting better. That's just telling you that you got a certain number of services. And then monitoring risk factors that can really undermine people's results, like health issues or pain, chronic substance issues that aren't being addressed, multiple medications that might be interfering, legal involvements, again, that are really undermining or getting in the way of other issues. And again, that idea of external or internal locus of control. If I have clients that just think that no matter what they do, the world's against them, it's going to be harder to get better outcomes with those kind of beliefs. So, all right. I think we're going to stop there and save this last few minutes for any questions or thoughts or reactions that you might have about that. Oh, I'm just going to bring up the other picture again here.
In the meantime, if anyone has a question for Dr. King, you're welcome to drop it in the chat or unmute yourself and you can go ahead and ask.
I would at least like to get your reactions and thoughts about the process and what you think and thoughts on its usefulness to you in your situation, if you're willing to share.
You're very easy to listen to. I could listen to you all day. You
Oh,
should have like a
good.
podcast drive around. I spend a lot of time in the car.
Soothing, okay. Didn't put you to sleep
Yeah,
though. Glad. Okay.
no, it's very interesting.
Okay.
I also like
I-
the visuals, the tree that you shared, because that helps to have the talk and then the visual to go with it.
Thanks. Yeah, I'm a picture person. I got to see it. So
I think what I was struck by was when you were citing those who said that even though we know a particular therapeutic means, I don't know, practice works, we don't always know how it works. And I was really intrigued by that because, you know, nowadays, especially around trauma, there are so many different modalities to choose from, and all of them are described as being evidence-based. It's a bit overwhelming, actually, if you work with anybody with a trauma history.
right. Yeah, and I'm not doubting that they have that they've found evidence with that particular model. And hopefully thinking about things this way helps to know why. Like there's a lot of different factors. And even when you know, I was in the community mental health setting and we were implementing specific evidence-based practice models, again, the issue is the implementation, right? You can have a great model, you can train everybody, but if some of these other factors aren't surrounding it, then it can still fail or it can still not get the kind of outcomes you're hoping for because of that. And even sometimes staff turnover affects that, right? So you have people that are turned over and not kind of getting to that level of expertise that they need to be to help folks. So, which is why I always go back to that idea of, you know, my goal was I'm trying to train you to be master clinicians because this isn't just about a particular model. It's about a lot more than that as well. And that I don't think we're ever going to, you know, we're never going to figure out all the components. People are complex, right? And they're not only complex, but they're developmental. And so not everything's going to work as clean cut as we want it to. It's just not going to happen. So, yeah. Thank you. Other thoughts? All right. Well, I really appreciate your letting me come today and give you all this information. If you have other questions, again, that you think of after or clarifications, feel free to email me and be happy to respond if that's helpful. So,
Thank you. Thank you very much.
Thank you, Dr. King, for imparting your wisdom with us today. A general survey will be sent out to those who are not needing CE, and those that are needing CE, you will receive a survey from me. And once it's completed, again, you will receive your certificate.